Okay. Um, Good morning. Welcome to the chapter 2 of language of ERCP module from Ramaya Memorial Hospitals, Bengaluru. So this chapter deals with the concept of sphincterotomy. So this is part of ERCP training at Ramaya. So what is the definition of sphincterotomy? So whenever we call it as a biliary sphincterotomy, it means that it is cutting of biliary sphincter as well as intraduodenal segment of bile duct following selective biliary cannulation using a high frequency current applied with the sphincterotomy. The first sphincterotomy was documented in literature by Kawai K et al. So it was published in Gastrointestinal Endoscopy in 1974. So what are all the different indications of sphincterotomy? So it is for extraction of bile duct stones, treatment of benign as well as malignant papillary stricture, so for placement of stents, treatment of sphincterophotic dysfunction, treatment of bile leaks, gallbladder drainage, as well as for removing any bile duct parasites, like sometimes ascaris can enter into the bile duct, sometimes for clearance of some syndrome or choledococele. In what conditions are you not going to do sphincterotomy? So in an unstable or uncooperative patient, or in patient whom the coagulopathy is not correctable, inability to orient a correct wire, the cutting wire in the direction of the bile duct, or if the person is on antiplatelets or anticoagulation, like we need to always look at why the patient is on antiplatelets or anticoagulation. Can we stop it safely or not? So whenever before we do this ERCP, so we should always ensure that the platelet count is more than 50,000, and the INR, it is always better to have it in the therapeutic range of less than 1.4 or less than 1.5. Aspirin monotherapy is safe for sclerotherapy, but if the patient is on clopidogrel, so we should always stop it at least 5 days before sclerotherapy in a patient who is having a low risk of thrombosis. Warfarin, if the patient is on anticoagulation, we can always switch it over to heparin, so that we can stop heparin on the day 6 hours prior to the procedure, and we can restart after 6 hours following procedure. Directly acting oral anticoagulants like dabigatran and all can be stopped 48 hours before sclerotherapy. So whenever we deal about sphincterotomy, so the instrument or the accessory that is used through the ERCP scope is basically sphincterotome. So whenever we call it as sphincterotome, there are different types. Either it is pull or push, or it is what is called as a needle knife. So whenever we say about pull or push sphincterotome, basically they have got a steel cutting wire at the end of a Teflon catheter. So the control of the cutting wire is by using a handle that is there at the proximal end of the accessory. So whenever the handle is tightened, the guide wire is moved away from the Teflon catheter, and then it will help in one is facilitating cannulation of the bile duct as well as facilitating the cutting the bile duct sphincter. So it is a monofilament wire, so which is connected to the electrode connected at the tip of the handle, which is connected to the monopolar electrosurgical unit. So sphincterotome, it is basically like earlier single lumen, double lumen. Now we always use a triple lumen sphincterotome, where there is a cutting wire as well as a guide wire and an injection port. So these are the three lumens that are used for three different purposes. There is a 2 or 3 centimeter cutting wire at the tip of the sphincterotome. So the tip size is around 5.5 French size. So there is a monofilament cut wire. The calibration of the distal part of the sphincterotome, so will be like it can be used for measuring the length of the bile duct. So Olympus have come with a clever cut sphincterotome, where the cutting wire has got an insulation at the tip of the cutting wire, where it avoids damage both to the scope as well as the proximal duodenal fold if at all it is coming in the in the plane of the cutting. So the bowing is such that the pre-curved design is in such a way that whenever we bow the sphincterotome, it is going to bow towards the 11 o'clock position in the orientation of the bile duct. There is a color coding, like to say like up to what depth the sphincterotome can be pushed inside for a safe sphincterotomy, and there are separate lumens both for the guide wire as well as cutting wire as well as injection. So how long should be the cutting wire? Majority of the cutting wires are 2 centimeters, but you can have a longer cutting wire up to 3 centimeters as well. The disadvantage of a long cutting wire is there is a leakage of current, and there will be a difficulty in bowing the cutting wire, because within the channel there will be a difficulty. So we should always do the cannulation little far away from the ampulla. So in adults, there will not be much of a problem, but whenever we are doing it younger people or person is little thin, so the long cutting wire can be a problem, because the selective cannulation from a far away position of the scope might be little difficult. So short cutting wire of 2 centimeter is much more easier, because the cannulation can be done from whenever we are closer to the ampulla. Whenever there is a difficulty in cannulation, always use a short cutting wire. What do you call by a nose of the sphincterotomy? Nose is like from the cutting wire till the distal end of the Teflon catheter. The distance is called as a nose. So whenever there is no nose, we call it as it is like a needle knife sphincterotomy. So whenever it is a short nose, like it will be aiding in difficult cannulation. Long nose, again we need to cannulate the ampulla from the far away position. So we can have a short wire design as well as a long wire design. In India, we don't have a problem with working hands. We can always have one or two assistants to help us. So we always take a long wire HSN system. But in Western people tend to use a short wire HSN system because we tend to feel like where the guide wire is going, we need not use much of the fluoroscopy evidence to see whether the wire is crossing the spine or crossing the scope to say whether it is entering into the pancreatic duct or entering into the bile duct. With just the manipulation of the wire at the tip of the scope, we'll be able to identify which way the wire is going. So needle knife, basically like in Olympus it comes like needle cut 3V, so it has got an outer Teflon catheter with the inner retractable cutting wire. So the advantage is there is no nose. So in a difficult cannulation, to expose the biliary sphincter, we tend to use the needle knife in stepwise fashion. We cut layer by layer towards the 11 o'clock position. So this we tend to use, this is called as needle knife sphincterotomy. We tend to use when the standard cannulation measures fail. And it can also be used for transgastric pseudocyst drainage. So earlier people used to use single lumen sphincterotomy, which was only for the cutting wire. Then it came to double wire, where there is a lumen for both the cutting wire as well as a guide wire insertion. So once a guide wire is inserted, we need to remove the guide wire, and then we tend to inject contrast to delineate the bile duct by a cholangiogram, and then we used to do that. So nowadays we have bypassed all this. We use only a triple lumen catheter. So whenever we use a triple lumen, the advantage is all three can be done without a wire exchange, but the only disadvantage is the amount of injection or the rate of injection of contrast, which is much lesser in contrast to the double lumen sphincterotomy. When you use pre-cut sphincterotomy, three definitions you need to look at. What is septotomy, what is needle knife papillotomy, what is needle knife fistulotomy. So the most important thing whenever you need to remember whenever you're using a needle knife is we should not be destroying the landmarks. That is, if you are starting your sphincterotomy from the ampulla upwards, we are going to cut upwards only. We are not going to cut in both the directions, otherwise we don't know where we have started, what is the starting point of sphincterotomy. So we are not supposed to destroy the landmarks. Pre-cut sphincterotomy is always only to cut the papillary mucosa, and we need to expose the underlying bile duct. It can be like you can use a little bit of suction so that the bile can start pouring in, or there will be like a nipple-like projection which you will be able to cut, and once you cut, you identify that it is a bile duct. So whenever you are using needle knife sphincterotomy, always ensure that the needle that is projected from the tip of the sphincterotomy is only 5 mm, and you should always maintain a close relation to the papilla. So transpancreatic sphincterotomy, it goes by the name what is called as a Goff technique, because that is a person, like he is a person who first reported in GI endoscopy in 1995. So here inadvertent, like we want the bile duct to cannulate, but the guide wire enters into the pancreatic duct inadvertently. So when it enters into the pancreatic duct, so like we always bow the sphincterotomy to cut the septum between the main pancreatic duct as well as bile duct. We always use a small cut, like a 5 mm cut, and it is made in a short burst. The advantage is we need not exchange the sphincterotomy. So within the same sphincterotomy, we are going to use a transpancreatic sphincterotomy, such that once you cut a 5 mm, after that we can either place a pancreatic stent according to ESG recommendation. We need to always place a prophylactic pancreatic stent, because otherwise the pancreatic sphincter can go into spasm and post ERC pancreatitis might be much higher. So we place a pancreatic stent, and after that towards the right of the pancreatic stent at 11 o'clock position, we target our sphincterotomy and we ask the assistant to push the guide wire across into the bile duct. Needle knife papillotomy comes is like once you identify that neither the pancreatic duct nor the bile duct could be cannulated, you keep the ampulla in N phase, and in stepwise fashion of 5 to 10 mm you make an incision with the needle knife. It is always advantageous when the papilla is very small. So we can start at the upper end of the papillary orifice, and then we direct our needle knife towards the 11 o'clock position, or like 1 o'clock position, depending upon whether we want the biliary or the pancreatic duct. Needle knife should always be kept in motion and it avoids thermal injury. So we can always repeat after 48 or 72 hours like if failed, because there can be chance of little edema setting in, there can be chance of little bleeding setting in. So we can always reattempt the needle knife sphincterotomy after 48 or 72 hours. The advantage of needle knife sphincterotomy is there is less chance of pancreatitis, as well as like whenever we are not aggressively cutting too much, crossing the upper end of the intraduodenal portion of the bile duct, so like less chances of perforation will happen. So we always ensure that we should cut only the like minimal, like 5 millimeters to 1 centimeter distance. In needle knife fistulotomy, the most important thing is we start from incision from the upper and middle, the junction of the upper and middle. So we start from up and then we cut down towards the ampulla. So it is done whenever the ampulla, like we find that it is very dilated, bulged, there is a stone at the ampulla, so then it becomes much more easier for us to do a needle knife fistulotomy. PD stent, the advantage is there are two things. One is it will aid in or assist in biliary cannulation, as well as it will guide in the sphincterotomy. It will reduce the risk of pancreatitis because it is bypassing the sphincter. So different stents are used. We preferentially tend to use a 5 French 7 centimeter stent, but in West and all they use much of a straight stent, because within 2 weeks or 3 weeks time, after it's serving its purpose, it is generally going to fall off. Whenever we use a 5 French stent, either single pigtail, we always tend to remove it after cholecystectomy is over, after we clear the bile duct as well as the pancreatic duct. Better, like we can choose a stent without any side flanges, because whenever there is a flange, there is less chance of migration. Whenever we use a single pigtail, then also there is a less chance of migration. How long the PD stent should stay? Majority of the time after ERC, if at all it stays for more than a day's time, majority of the time it has served its purpose by reducing the chance of post ERC pancreatitis. Electrosurgical unit, whenever we are looking at what is the current that we are going to use, either it can be a pure current or it can be a coagulation plus cut current, as well as a mixed current. Mixed current can be in two forms, can it be blended or alternate mode, which is basically like endocut mode that we majority of the time we use. Blended mode is where there is like a cutting and coagulating current are blended into a single waveform, whereas in an alternating mode there is a cut and after that there is a coag. It is not in the single wave, so it is alternate mode. So majority of the time we use endocut mode or what is called as a pulse cut mode. The pure cut mode is associated with more episodes of bleeding and less episodes of pancreatitis, because there is no coagulating current that is going to cause the sphincter spasm. There is a lower bleeding episodes with alternating mode compared with the blended mode. So always ESG recommends that we should use mixed current in alternating mode for endoscopic sphincterotomy. So what is the technique of sphincterotomy? So we always try to get the guide wire first. So we pass the guide wire. Earlier we used to use contrast as a directing measure, but we always want the right hand assistant to push the guide wire across. Guide wire provides the anchor during the sphincterotomy. Once we push the guide wire into the bile duct, the guide wire is crossing the scope. We are sure that it is the bile duct that we have cannulated, or it is a duct of choice. Like we pass because 80-90% of the time it is a biliary indication that we tend to do. That way majority of my presentation will be towards the bile duct. We pass the sphincterotome over the guide wire. We pass it approximately up to the hilum, because we always inject contrast. We need to delineate the bile duct, because how much are we going to cut will be determined by what is the indication for the sphincterotomy. So we always inject contrast from hilum down, such that we fill the bile duct and we don't inadvertently fill the cystic duct and the gallbladder. So once the cholangiogram is done, we identify the pathology, then you come down. So like till the sphincterotome, you are able to see the cutting wire. You are going to bow the sphincterotome such that you are going to put the cutting wire in line with the intraduodenal portion of the bile duct. Only 1/3 of the cutting wire should be inside, 2/3 should be outside. So more of a right deviation. So such that if at all there is like you torque more, so there can be higher chance of going towards the pancreatic duct, as well as higher chances of perforation chances will be high. So we always tend to deviate towards the left, and then we tend to cut. Blended current in short bursts to deroof the papilla in stepwise motion, that is the technique of sphincterotomy. Blended current, that is cut plus coagulation. In short bursts, and we should deroof the papilla. So whenever there is a whitening of tissue upon passage of the current, that means that is the beginning of the cut. If the tissue doesn't blanch after passage of the current, that means we should have an adequate contact of the tissue with the sphincterotomy. If there is a too less of a contact, then it creates more of gas. Like we don't want too much of a gas, so we should ensure that adequate tissue is connected to the or adequate tissue contact with the cutting wire. So we should also ensure that whenever we are bowing the sphincterotomy, we should ensure that too much of the duodenal folds are not happening, because whenever there is a too much of a duodenal folds, that means the wire acts on a tension. Whenever there is excess tension is applied, that there can be a chance of zipper cut. So that is very important. So we should always orient, so like the duodenoscope, so we should always see what is the starting point of the cut and is it in the desired portion of the cut. Excessive bowing should be avoided because there can be a chance of zipper cut. In a short scope position, not achieving the proper orientation, we can always push the scope such that the scope can fall onto the greater curve of the stomach, and then it can in the long scope position you will be able to orient towards the 11 o'clock or the 1 o'clock position, whether it is a biliary or the pancreatic sphincterotomy that we are going to do. We can always ensure that whether it is a small sphincterotomy or a large sphincterotomy, but the thing is there is no standard size, or whether it is the indication of sphincterotomy that is going to. It's always what is the safety limit. So we are not going to cut beyond the fold of the duodenum, because otherwise once you cross the fold of the duodenum or the ampullary fold, there can be chance of perforation. So if at all there is no much of the scope to cut, we can always use a sphincteroplasty, that is use a regular CRE balloon. We can dilate the sphincter such that we can do the endotherapy much better. Whenever we use a re-EST, that is second time EST, there is higher chance of hemorrhage after the primary one, because there is a documented literature which shows that there is increased vascularity. We should always be little careful whenever we are re-attempting ERC, because re-EST has got increased chance of bleed. What are the complications of sphincterotomy? Bleeding, pancreatitis, cholangitis, damage to the surrounding tissue, and perforation. Post-sclerotherapy bleeding, this is immediate. It can be self-limiting or it can be delayed up to 2 weeks. Around 0.1 to 2% of the chance of bleeding can be there. Hemoglobin drop can be minimal or it can drop significantly up to 2 gram per liter. Arterial vascularity in an anatomical study, so we can see that at 10 o'clock or 11 o'clock position around the bile duct, the arterial vascularity is lesser. So once it comes towards the 1 o'clock or 3 o'clock position, the arterial vascularity around the ampulla is much more. So whenever we tend to orient towards the right, so that means it is a danger. So it's always better to orient our scope as well as the sphincterotomy towards the left, towards the 11 o'clock or a 12 o'clock position. Proven risk factors for post-sclerotherapy bleeding are any coagulopathy or thrombocytopenia, active cholangitis, any anticoagulant therapy within 3 days after ERCP, or a low experience of the ERCPist, as well as if the volume of the ERCPist is much lesser. These are all the proven risk factors. Possible risk factors are like in a cirrhotic patient, or it is a dilated bile duct, or a periampullary diverticulum is there, or a re-EST, like a second time we are doing a sclerotherapy, or an ampullary stone impaction, there can be a chance of bleeding. We should always correct coagulopathy. We should avoid zipper cut. If bleed is noted, we can always use a stone extraction balloon, and we can use it like a scope tamponade, the balloon tamponade. We can always place a biliary stent, and we can inject. Once you place a biliary stent, majority of the bleeds will be from the top of the cut. We can always inject dilute adrenaline at the top to control the bleed. No trials should we be using a thermal injection or a hemoclip, because in endoscopy we always have three, like we always need to do dual modality of treatment, but here it is very difficult to apply clips using the side wing scopy. In a regular forward wing scopy, the ampullary position will not come in phase. So it's always better that we always inject, and if at all it is not settling, like angiographic embolization or surgery will be the rescue. Post-ERC perforation, like there can be chance of, this is most common cause for post-ERC perforation. It is majority of the time type 2 perforation, because type 1 is predominantly on the lateral wall of the duodenum because of the scope reduction. Type 2 is at the ampulla because of the sphincterotomy. So the diagnosis, like majority of the time, patients will come with severe epigastric pain and tenderness immediately after the procedure. Immediately after the procedure, if the person has got that, then we should suspect that it is not pancreatitis, it is perforation. If they develop peritonitis features, then they can have fever, tachycardia, tachypnea, and generalized abdominal rigidity might happen. On fluoro we can see a free retroperitoneal layer, or the pseudo kidney sign you may be able to find out. We can always inject little bit of contrast and we can see a contrast extravasation into the retroperitoneum. CT with oral contrast can be decent enough to identify little bit of small perforation, but amount of air within the abdomen doesn't correlate with the size of perforation. The risk factors for post-ERC perforation is whenever we extend the sphincterotomy beyond the intraduodenal portion of the bile duct, or there is a wrong direction of the cut, as well as a needle knife pre-cut sphincterotomy, or in cases of sphincteropody dysfunction. What is the preventive measures? Like limiting the length of the cutting wire inside the ampulla, cutting in a stepwise fashion rather than like a zipper cut, microprocessor controlled, like your right hand assistant should be also like the bowing the sphincterotomy much lesser, otherwise high chance of zipper cut and perforation. And only 1 in 5, like after you document that there is a perforation, only 1 out of 5 will require surgery. The goal in surgery post ERC perforation is only to prevent retroperitoneal leakage as well as contamination. We can always place a fully covered metallic stent to cover the perforation if at all it is very obvious on the ERC. Medical line of management is keep the patient nail by mouth, IV fluids, NG tube, PPI, antibiotics, and if at all there are any telltale signs of peritoneal irritation or SARS features, then surgery should always be kept in the picture, because if at all there is a significant leak or development of peritonitis features, so they can always do surgery and then put in significant drains. Like majority of the time they may not be able to identify what is the site of perforation, like they may do a proper peritoneal lavage and then come, unless or until it is an obvious perforation where they may do a primary closure. The most common complication after a sclerotherapy is pancreatitis. So there are multiple causes for pancreatitis. One is like the patient factors or the procedure factors. In the patient factors, like an young female, like person having normal bilirubin, like an anictic hepatitis, suspected sphincterotomy dysfunction, or earlier documented episodes of post-ERC pancreatitis, and there is no underlying chronic pancreatitis. These are all the patient factors that may determine that this person might develop a post-ERC pancreatitis. Procedure related are difficult ERC procedures, like longer time taken for cannulating, like pre-cut sphincterotomy is used, pancreatic tissue sampling is used, guide wire cannulation, pancreatic duct injection by using a contrast inadvertently or advertently, and a balloon dilatation, that is using a sphincteroplasty. At that time there can be chance of irritation of pancreatic sphincter and then causes post-ERC pancreatitis. Post-ERC cholangitis, the risk factors, like it occurs in 1 to 3% of the ERCs. It happens when there is incomplete biliary drainage, when there is a combined percutaneous as well as endoscopic procedure. So jaundice caused by malignancy, suppose it is a cholangiocarcinoma at the distal end of the bile duct, then there might be high chance of post-ERC cholangitis, because we need to place Amsterdam stents such that the drainage is much better. Always the goal is to have an adequate biliary drainage. We always flush the contrast out of the biliary system, because contrast is always viscous. Post ERC stent blockers will be much higher. So always try to place, if at all there is a stricture, rather than placing one stent, we can always place multiple stents such that the stents will aid in drainage. If at all it is a cholangitis, that is an indication for ERC, minimize the contrast that is used. Always aspirate some amount of bile before we inject contrast, such that the intrabiliary pressure is not increased and systemic symptoms will not come. Long-term complications like recurrent common bile duct stones might happen. Cholecystitis can happen because of the contrast going into the gallbladder. Some of the literature says about chemical cholecystitis. Cholangitis, hepatic abscesses, papillary stenosis, all this can happen. The risks are like whenever there is a large periampullary diverticulum, dilated bile duct, or incomplete clearance of gallstones, as well as mechanical use of lithotripsy. What is the safe and danger zone? The safe zone is 11 or 12 o'clock, and the danger zone as we come towards the 1 o'clock or 2 o'clock, because there can be chance of bleed or perforation. Ampulla and papilla, these are used like almost synonymously. Like ampulla is a dilated part of the duct, topographically determined by the dilatation of the confluence of CBD and the MPD. Once that is bile duct, common bile duct and the main pancreatic duct joins and then forms a mound on the duodenal portion, then we call it as an ampulla. The first description is not by ampulla, we always call about ampulla of Vetter. The first description is by Santorini, but not Vetter. So papilla of Vetter is an eponym, so like we tend to use more often ampulla rather than papilla. So when do you say that the sphincterotomy is adequate? One is there should be a gush of bile that should be coming from the bile duct. Second thing is a bowed sphincterotomy should be able to, that is fully tightened sphincterotomy should be able to pass freely into the bile duct, as well as the adequacy of the cut will be determined by what is the diameter of the distal duct and what is the shape of the ampulla. So suppose the papilla is flat, we are not going to cut much. We are going to use a balloon sphincteroplasty depending upon what is the indication. The cut should not go beyond the impression of the bile duct on the duodenum. Pancreatic sphincterotomy, the difference between biliary and the pancreatic sphincterotomy is there should be a proper orientation, because the pancreatic axis is towards 1 or 2 o'clock, not the 11 o'clock typical of biliary. So only a small amount of wire is going to be placed into the pancreatic sphincter. Better to use a pure cut whenever you are using a pancreatic sphincterotomy. We preferentially tend to use a smaller guide wires. Instead of using 035 guide wires, we tend to use 021 or 018 or 025 guide wires, because we tend to place the guide wires up to the body. We don't place it till the tail. So up to the body, distal body, we tend to place the guide wire, and then we see. The rules are we cut till the septum between the bile duct and pancreatic duct is noted. So like we are not going to use a completely bowed sphincterotomy. The bowing should be only slight. The cut should be only a 5 millimeter. And whenever we do a pancreatic sphincterotomy, always place a pancreatic stent, because there can be a chance of edema of the pancreatic sphincter, and post ERC pancreatitis can happen. Typical cut is again 5 to 10 millimeter. Complications can be similar, like bleeding, perforation, pancreatitis, and more than 3 months long term there can be chance of pancreatic structure and then stone formation. Always place a PD stent, because the pain relief can be 60 to 70% in a chronic pancreatitis scenario. Minor sphincterotomy, like this majority of the time we use when pancreas divisum endotherapy is done. Needle knife is used. Guide wire cannulation is like followed by placement of 3 French or a 5 French PD stent. Like through the minor papilla, we are going to place in minor papillary sphincterotomy. Is cannula better or sphincterotomy better? The only difference is it is all user expertise. We preferentially tend to use sphincterotomy, because you need not exchange the cannula for the sphincterotomy. Second thing is the cutting wire will, whenever we bow, like it is going to aid in cannulation. So like there is no single type of sphincterotomy which is superior or one or other. It is all like the more we use, the more we do, the better we become. So whether we should be starting with 0.25 inch guide wire or 0.35 inch guide wire, again it is all individual preference. So if at all we are dealing with the stricture, it is always better to use a smaller guide wire, and then we can always change it to a stiffer wire, such that we can pass different accessories. Bilrod 2 anatomy, the problem is there is an antrectomy as well as a gastrojejunostomy that can happen. Afferent limb can lead to the ampulla. Efferent will be to the distal bowel. So always do an endoscope, place a guide wire across, such that we can thread the guide wire over the scope, such that you can pass the duodenoscope much easier. Otherwise sometimes there can be a chance of gastrojejunostomy giving way. So we can always use like a standard biliary sphincterotomy, but the problem is the orientation is little upside down. The bile duct will come at 5 o'clock or 6 o'clock, so cutting will be much of a problem. So like forward viewing scope, we can do a ERC, but only problem is you will not be able to control your accessory, because there is no elevator in the regular upper GI scope. So how much cut, again it will be difficult. So majority of the time we tend to place a stent, and then we tend to redo a procedure after some time by using a sphincteroplasty. So what is the problem with coldocholithiasis after cholecystectomy? It can happen in 10% of the people. So like ERC and sphincterotomy can be successful in 85 to 90% of the cannulation. Of the stone clearance. EUS is always used in failed cannulation, both for rendezvous procedure as well as for antegrade approach, like using a 19 gauge needle. We puncture either the bile duct or the hepatic duct, and then we pass the guide wire, which can be taken out from the ampulla, and we can use a rendezvous procedure. So we can always do both biliary sphincterotomy as well as a pancreatic sphincterotomy by using a double wire technique. Like it can be useful especially in a patient who has got a chronic pancreatitis with a cholangitis, with a dilated bile duct, with a bilirubin more than 5. So where we need to do both the sphincterotomies. Like it's always better to complete ERC both biliary as well as pancreatic endotherapy in a single session. In pancreas division, the most important thing is the minor papilla results in opacification of dorsal pancreatic duct up to the tail, whereas from the regular ampulla, you may not be able to opacify till the tail, so that duct will be little smaller. Which strictures are amenable? Like head and body strictures, like they are amenable, because tail strictures, like it's always better for them to undergo endotherapy. So multiple strictures, if at all there, then also it will be difficult for endotherapists, because we are working at 1 meter or 1 meter plus another 20 centimeter distance. So the amount of pressure that we are going to generate might be little lesser. So if at all there are multiple strictures or a tail strictures, like endotherapy is a definite no. Proximal strictures like a head stricture or MPD beyond the stricture is more than 6 mm, always they are amenable for endotherapy. Dominant PD strictures should be treated with stents, and we always exchange stents once in 6 months or once in a year. Whenever there is a pancreatic duct leak in traumatic pancreatitis or chronic pancreatitis with ductal disruption, like we need to document where exactly is the leak. So PD leak is the extravasation of contrast from either head body. We can always bypass the leak by placing a stent. If at all it is a tail, most likely they may end up with surgery. But the thing is, in biliary, it is only the treatment is biliary sphincterotomy will reduce the biliary pressures. We need not bypass the biliary leak, but in pancreas it is a gland, so we should always bypass the leak. So disconnected pancreatic duct syndrome, so that is basically complete continuity of the pancreatic duct. My friend Dr. Anup Koshi has put from the distal end into the stomach and has done a pancreaticogastrostomy under US guidance. But more amount of literature has to come, like how are we going to treat a disconnected pancreatic duct syndrome. Pseudocyst again is a different problem. We need to see where is the maximum extrinsic compression. Should we doing with a regular side wing scope or under US? US is always preferable, because we know how much is the wall thickness, any underlying vessel is there or not. We puncture under guidance, so it will be much better as well as safer. Like in a regular duodenoscope position, we use a needle knife. We maintain the perpendicular position such that the passage of accessories are much better. So whenever the cyst to stomach wall distance is more than a centimeter, vascular structures are projected in between, or there is a chance of bleed always, or the debris within the cyst is much more, there is high chance of infection within the high chance of infection that can happen. Like we should always ensure that what is the ideal time, like only in a symptomatic cyst we are going to go for a cystogastrostomy. This completes the chapter 2 of language of ERCP module. Thank you. Break.